Hello, I'm Jeffrey Reist, and I'm a clinical assistant professor here at the College of Pharmacy at the University of Iowa. And today we're going to talk about nursing home regulations as they relate to psychotropic medication use. I have nothing to disclose. I have no financial relationships with anyone, manufacturers of products or services. The learning objectives are on your screen. I'm going to just briefly talk about the nursing home regulations themselves. We're going to try to define some of the terms that are used in the nursing home regulations, such as unnecessary medications, listing some of the specific medications mentioned in the regulations. Hopefully, at the end of this presentation, you'll be able to evaluate a nursing home resident's medication regimen for some of these potentially unnecessary medications and make recommendations to maintain adherence with the regs. And also to develop appropriate monitoring plans so that when these medications are necessary, we will be able to appropriately monitor our patients and residents. The nursing home industry, as we know, is very highly regulated. There are hundreds and hundreds of pages of regulations in Appendix PP of the State Operations Manual, from which the regulations that we're going to talk today are located. There's several that deal directly with medications, and there's quite a few actually that deal kind of indirectly with medications. The ones we're going to talk about today are the Pharmacy Services Reg, which is the FTAG 425 and F431, the Drug Regimen Review, which is F428, and unnecessary medications, where we're going to spend most of our time today, which is the famous F329. Appendix PP of the State Operations Manual is listed at the final slide as my main reference for this talk. This is a lengthy document. It's about 665 pages. And the unnecessary med reg, the F329, takes up about 80 pages of that document. So briefly, to understand where we're coming through from with all of these, the medication regs we're going to talk about, is we have to understand the pharmacy services in the nursing facility. Pharmacy services have been a part of the regulations for decades. My background as a nursing home consultant pharmacist started in the 1980s, and at that time, pharmacists were required to do nursing home med reviews, as they are today. The Pharmacy Services Reg basically talks about the role of the pharmacist overseeing all aspects of medication use. We're not going to talk about all aspects today. We're going to mainly talk about another regulation, which is the Drug Regimen Review Regulation. The Drug Regimen Review Regulation states that a pharmacist must conduct a monthly medication review on each resident in a nursing facility. However, I can tell you that these days, with the higher level of care that many nursing home residents require, I personally believe that a monthly med review is maybe not adequate. Certainly, there are certain residents that could require much more frequent medication reviews, and that's going to be pretty much up to the discretion of the team taking care of the resident. But regulation-wise, it is a requirement of monthly. The results of the medication review really need to be reported to both the director of nursing and the attending physician. And importantly, those findings of that report must be acted upon. The goals for the drug regimen review are pretty straightforward. We really want to make sure that our residents have attained the goals of their therapy, whatever that may be. Everything from appropriate target levels of blood pressure, lipids, behaviors. So any appropriate goal of therapy, we want to assure appropriate monitoring. Many medications require periodic monitoring, and we want to make sure those occur. And then we also want to identify any potential medication-related causes of symptoms or changes in conditions. And this is really where a lot of the background behind the unnecessary drug regulation comes from, because we know that medications can be a significant cause of morbidity in patients of all ages, and particularly our older adults. Behavior changes, cognitive decline, falls, dizziness, constipation, sedation, all can be significant side effects of medication that can be quite devastating in the older adult. And that is one of the roles of the pharmacist and the other members of the healthcare team, is to try to identify those when possible. The unnecessary medication reg, which is where we're going to spend the rest of our time. Again, in the State Operations Manual Appendix, it is listed under F tag 329. Again, it's about 80 pages. There's a tremendous amount of information there, and really, there is a lot of very good monitoring information for many, many drugs. There's a Table 1 within the regulations, which I would recommend that anyone that is interested in reviewing medication regimens for appropriateness in nursing home residents, take a look at that. That Table 1 has, in addition to the classes of drugs that we're going to talk about today, the psychotropic medications, it lists medications all the way from cardiovascular agents, including blood pressure meds, warfarin, all the way to medications used for urinary incontinence. And it lists a lot of very good monitoring parameters, and it can be a very good resource. So I would encourage you to take a look at that. And it's Table 1. It is located in Appendix PP of the State Operations Manual. So the unnecessary medication regulation in general is pretty clearly defined in the regulation. It basically defines a potentially unnecessary med as any drug when used in excessive dose, duration, without monitoring, or in the presence of some of those adverse consequences that we just talked about, the side effects, if you will. I don't particularly like the term unnecessary med. It tends to put us all a little bit on edge. I really wish they would have called this regulation something else, maybe medications to be vigilant about or something like that, but it is what it is. It is called the unnecessary med regulation. But remember that based on the definition, any drug could be considered an unnecessary drug. The regulations tend to focus on the classes that have been known to cause most problems in older adults, but truly any medication, an antihistamine used for allergies, if it's not adequately monitored or if it has extreme side effects, could be an unnecessary drug. A drug for urinary incontinence with anticholinergic side effects could certainly be considered an unnecessary drug. So the regulation does not or is not limited to the class of drugs that we're going to talk about today, which are primarily psychotropic drugs, but it certainly can be applied to any drug in any category. Now, the unnecessary drug reg does list some very specific medications and classes of medications. The three general classes that are represented include two fairly narrow classes, the antipsychotics and also the sedative hypnotics, or agents to induce sleep. But then there's a very broad category, which is relatively new to this regulation, and it is called the psychopharmacological medication category. And this broad category is really defined by how a medication is used or what that medication is being used to treat. So the diagnosis or indication, if you will. I'm going to take these one group at a time, and within each group we're going to talk about some examples. We're also going to talk about some monitoring parameters that we would want to include in our care plans, and we're also going to talk about that issue that always comes up, which is the gradual dosing requirement or dosing reduction requirement. So we're going to start with antipsychotics. Antipsychotics have been mentioned in some form or another in regulations for many, many years. They were really one of the first classes of psychotropic drugs that were targeted by regulations. This was probably due to back before regulations dealing with these agents, the use of antipsychotics was fairly widespread in nursing home residents. I can remember back in the mid-'80s when I really started this, it was fairly common to have a large percentage of residents in nursing facilities on an antipsychotic of one form or another, some of which were even very, very inappropriately used and really considered more what we would call today chemical restraints. So the antipsychotics have been regulated for a long, long time. And I think most of us are aware of most of the regs, but I will go through them today for completeness. So basically, if a person is coming into a nursing facility, or if they are in a nursing facility and we're going to consider using antipsychotic medications, we better have some pretty good reasons for that, is what this regulation says. And if we're using them for behaviors primarily, we're going to have to do some gradual dose reductions and have some very well documented behavioral interventions, unless clinically contraindicated. The goal for these agents, when used for behaviors associated with primarily dementing type illnesses, is really to discontinue these agents as quickly as possible. So there's basically two general categories of use for antipsychotics. The true, and I hate to use the term, but the true psychiatric diagnoses, such as schizophrenia, bipolar affective disorder, depression with psychotic features, various what we would call psychiatric diagnosis is one category of use. And then the other major category of use, primarily in older adults, is dementia-type illnesses with associated behavioral symptoms. An example of this would be Alzheimer's disease. The reason why it's important to consider these two basic categories of use is because their intended use will dictate some of the requirements of our monitoring and our gradual dosing reduction requirements. In addition to a diagnosis, we do need to have a clinical condition to include, documenting why these agents are necessary. And you might say, why are we so concerned about all of this with this class of drugs? And I'll tell you that the main reason is because there are some potentially serious, very much sometimes life-threatening or permanent side effects associated with these agents that mean that their inappropriate use should really be discouraged. Antipsychotics have what we call an FDA black box warning. And a black box warning from the FDA is, although it is becoming more common now than it used to be, but it really requires the labeling of the drug from the manufacturer to include some specific warnings that the FDA approves. And it usually is something that the FDA does not take, when they create a black box warning, it's usually with pretty good thought and background. The black box warning associated with antipsychotic use in the elderly basically states that these agents are not indicated for the treatment of dementia in the elderly, and there's actually evidence to support that they can cause death when used in the elderly for these conditions. And that's a pretty serious warning. And so we as members of the healthcare team really need to be thinking about that. And I will tell you that I've talked with many family members about their loved ones that are on antipsychotic medications, and when they read that black box warning, there's a lot of concern there, and rightfully so. So we do need to keep that in mind, that these agents have been shown to be possibly quite dangerous in the population that we generally deal with of older adults. So getting back to the antipsychotic use criteria, in addition to the diagnosis, we have to have at least one of the following criteria met. Certainly if the symptoms are due to mania or psychosis, such as hallucinations or paranoia, these are the drugs of choice for those conditions, and that creates a very important need for these medications. Another criteria would be if the behaviors that the resident exhibits present a danger to themselves or others. Things such as maybe hitting or aggressive behavior toward other residents or staff. We do need to remember that many of our residents in the nursing facilities are unable to defend themselves from aggressive behavior. So if we have a person that is causing danger to others or themselves, if the resident is engaging in behaviors that could cause mortality or morbidity for themselves, that can be a criteria for antipsychotic use. And certainly, if the symptoms of their dementia-type illness result in persistent distress, decline in function or ability to receive care, that can also be an appropriate criteria for use of these agents. Examples of that would be constant fear, which results in constant screaming or yelling. That is actually manifestation of a very distressful situation that the resident is experiencing. Certainly not eating and resulting in weight loss and clinical decline, or not allowing cares or bathing, which could result in skin breakdown and other problems. So before we start anyone on antipsychotic use, we really need to rule out that these behaviors that we're trying to control and eliminate or ameliorate are not due to other conditions, such as medical conditions. We know that hypoxia, pain, certain infections can cause behaviors and cognitive changes. Certainly environmental stressors, being hungry, thirsty, being in an unusual place, change in location, going from one level of care to another, we know has an effect on cognition and behavior, and also psychological stressors, just being lonely or having maybe a history of abuse. All of these can result in behaviors, and often there are better treatments for them than antipsychotics. The antipsychotics may mask the problem, but we really want to treat the root problem. And certainly many of the agents that we can use to treat things like medical problems, pain, certainly come with much less potential for side effects than the antipsychotic class. So we want to use those whenever possible. We've all heard of target behaviors, so we do want to, I want to talk about those for just a minute. Target behaviors are really defined as those behaviors associated with the condition we're treating, for which we hope these medications will be effective. Target behaviors need to be specific. They need to be objective and quantitative. They need to be monitored every day, preferably every shift. And we need to avoid subjective target behaviors. So an example of an objective and quantitative behavior is, hitting others 3 times a day or 3 times during the day shift. That would be very objective and very quantitative. If I read that in a patient's chart or on their behavior monitoring form, I will know exactly what's happening. I know what hitting is, and I know what 3 times is. In contrast to that, we want to avoid the more subjective target behaviors like agitation or even generalized anxiety. Agitation is somewhat undefined. I may think of agitation as a physical behavior. Someone else might think of it as a motor behavior. So that's 2 totally different things, and it may mean that this medication is either appropriate or inappropriate. So we want to avoid those somewhat undefined or more subjective target behaviors, and certainly we want to avoid terms like continuous or all day or most of the shift, things that are really not quantitative. So a number is good and a very specific behavior. And that way, when a person looks at the indication for use of this medication and the continued use, they can actually make a better judgment. So monitoring for adverse effects. Remember I said that the reason we want to avoid using these medications whenever possible is because they do have a fairly high potential for adverse effects, some of which can be quite serious, resulting in death or permanent disability. So we do want to monitor for those, and we want to make sure that if they do start to occur, we can take action to reduce the dose or eliminate the medication whenever possible. I've listed here the common antipsychotic adverse effects. I'll let you read those. But the main ones we're concerned about that can cause some real problems are the anticholinergic side effects, things like dry mouth, constipation, dizziness, and confusion, as well as the neuromuscular, the Parkinsonian symptoms, the tremor, the shuffling gait, the akathisia, or just the internal restlessness that occurs. Also, orthostatic hypotension. I really recommend on patients maintained on antipsychotics that we have some orthostatic blood pressures monitored at least monthly in the chart. That can help us to identify potential orthostasis, and which could result in falls. And we definitely have to do everything we can to prevent falls in our older adults. The newer antipsychotics, like olanzapine, can often cause what we call metabolic syndrome, which basically results in inability to control blood glucose. It can result in hyperlipidemia or high cholesterol, certainly weight gain, and all kinds of cardiac sequelae from those conditions. And also the sudden death that is mentioned in the black box warning can certainly occur. And let's not forget tardive dyskinesia. Tardive dyskinesia, we believe, might be a little bit less common with some of the newer agents, although it still occurs. And remember, tardive dyskinesia is that involuntary facial, mouth, tongue movements that's very disabling to people. It can actually result in extreme difficulties in weight loss, especially if there's false teeth involved. And oftentimes, tardive dyskinesia can be a permanent side effect even after the medication is discontinued. And again, I just want to mention that, because of adverse effects, the FDA has put in a black box warning for the use of these agents for dementia in the elderly. And if you're not aware of that, I would encourage you to go to the FDA website, or actually just ask your pharmacist to give you a package insert for any of these drugs, and you'll see that. Many of the side effects associated with this class of drugs are dose-related. So the regulations for some of the agents have very specific maximum daily doses that if we're going to exceed those, we're going to have some really good clinical reasoning in the chart to defend that. I've put the doses that are out there for commonly used antipsychotics. There are some others that are not as common, but the ones on the left-hand side of the screen are the more traditional, or what we call the older or first generation, or what we call typical antipsychotics. Those on the right side of the screen are more what we call the second or the atypical generation of antipsychotics. Brand names that you might recognize in that group are Risperdal or Zyprexa, Seroquel, or those on the right side. So how long should we use antipsychotics in a given resident? That's the big question. So unless clinically contraindicated, we do have to try periodic, what we call gradual dose reductions, or GDR. So what does that mean, clinically contraindicated? Well, we'll talk about that in just a moment. But if that GDR, or gradual dose reduction, is not clinically contraindicated, then within the first year in which we start a resident on one of these agents, or they're admitted on one, we need to try a dose reduction on 2 separate quarters of the year, and we have to wait about a month between attempts. So this has kind of been interpreted to mean approximately every 6 months, maybe every 4 months, but they have to be in separate quarters, like first quarter of the year, second or third quarter, and we have to wait a month between attempts. After 1 year of this, we need to continue this gradual dose reduction, and we need to try that at least annually. So when would it be contraindicated to do a dose reduction? If we have evidence based on those target behaviors that we've talked about, we have good evidence that says that when we've tried this in the past, those target symptoms have recurred or worsened, and we have documentation, and this has to be from the physician, that any additional attempts would impair the resident's function or cause increased distress behavior. So that's 2 things that have to occur. We also need to remember those 2 broad categories of use of antipsychotics. There's the true, what we call psychiatric disorders, things such as schizophrenia, bipolar disorder, mania, any kind of hallucination, associated psychosis. When these agents are used for those conditions, as long as that use is in accordance with current standards of practice, or again, the target symptoms have recurred or become worse, then we really don't have to worry about the gradual dosing reduction. So if you have a patient in your facility that has schizophrenia as a diagnosis, it's actually probably very unwise. If a person with schizophrenia is well controlled on one of these agents, it's probably very unwise to try these gradual dosing reductions, unless you feel that there are side effects that you want to try to deal with, and maybe a lower dose would work. But the bottom line is it is not a requirement to do the GDR in such a patient. Before we go to sedative hypnotics, I do want to just mention one thing. People might say, why, if a person's behaviors are controlled? Let's say the person has a dementia type illness, say Alzheimer's disease, and they're well controlled on their antipsychotic. You might say, well, why are we going to mess with that? Why are we going to attempt a gradual dosing reduction, which may result in those behaviors coming back? We do need to remember what happens with a disease such as Alzheimer's disease. We have to remember the clinical course of that disease. Many times in the earlier stages of Alzheimer's disease, there is frustration and anger on the part of the nursing home resident that often can be manifested in behaviors. As the course of the disease progresses, however, oftentimes those behaviors become less of a problem. If we start a medication for those behaviors at the earlier onset, earlier stages of the disease, at some point, those medications will no longer be necessary. And the only way to know when we've reached that point is really to try the gradual dose reduction. So that's the clinical rationale behind this. And I realize that sometimes in practice, it's kind of hard to get your arms around that. But remember, as the disease progresses, many times the need for these medications kind of dissipates. And because of their side effects and the fact that there are some clinically significant problems with their long-term use, we do want to maintain people on the lowest possible dose and certainly discontinue whenever possible. So let's go ahead and shift gears to the use of sedative hypnotics and the unnecessary medication regulation as it relates to sedative hypnotics. This fairly narrow category is really talking about those medications we use to treat insomnia. We're not talking about sedatives as far as anxiety. There's a whole other section that we're going to talk about in a little bit about anxiety, but we're really talking about sedative hypnotics used for sleep induction or to treat insomnia. Certainly, this has been a long-standing regulatory issue in long-term care. Many of the agents we have not been shown to be safe and or effective for long-term use. Most of the use, if you read the manufacturer's indications, are for short-term use. Some as short as 7 to 10 days, some for up to a month. But with the exception of one that I can think of, most of them have very specific time limitations as far as how long they should be used. So certainly before we use sedative hypnotics or when we're trying our gradual dose reductions, we need to try some non-pharmacological interventions. Things such as improving sleep hygiene. We also need to realize that when these agents are used for short-term use for procedures, for example, if we need to provide something to relax someone before dental procedures, or at the early stages of treatment of another condition such as depression or pain, until those symptoms have been identified and treated, it is quite appropriate to use these agents. Again, as with the antipsychotics, we want to rule out other factors that might be contributing to the insomnia or the need for a perceived need for a sedative hypnotic. Things such as environmental factors, maybe it's a light issue, noise, heat, or cold. Nursing facilities, sometimes depending upon what room the resident is in, may be noisier or more subject to light than others. Certainly caffeine or other medications. If a person is on stimulating medications, such as some of the decongestants or agents for asthma, we can certainly have stimulation from those medications, or even caffeine. And caffeine, we know, is hidden in lots and lots of different agents. Coffee, of course, is the most common, but certainly chocolate and other kinds of foods, energy drinks, etc. Inadequate physical activity, facility routines, provision of care, and certainly underlying conditions. If we have pain as an underlying condition, certainly that can interfere with our sleep. Other conditions such as heart failure, COPD, restless leg, and don't forget urinary tract problems, especially like in males that might have some BPH. Possibly, they're getting up 3 or 4 times a night to go to the restroom. Maybe it's a matter of adequately treating the prostate condition, and that will help with the insomnia. Again, what we want to avoid here is that thing we call polypharmacy, where we end up using a med to treat a side effect of another med or to mask symptoms of a disease that isn't adequately treated. Okay, so prior to initiation, we want to make sure that we use good sleep hygiene. And good sleep hygiene is certain practices such as a routine time for retiring, avoiding watching TV in bed at night to try to fall asleep, avoiding stimulating drinks and beverages or eating right before bed, primarily using the bed for sleep. Those are just all good sleep hygiene practices. And it's amazing, how just doing some of those non-pharmacologic actions can improve a person's ability to sleep. Sometimes we need to individualize the sleep and wake times to accommodate the resident's wishes. Maybe the person doesn't want to go to bed at 10:30 every night. Maybe they've been a night owl for most of their life, and they like to go to bed at midnight and wake up at 8 or 9. Why can't the resident do that? So we need to think about, what is the resident's wishes as far as retiring time and waking time. And certainly, as I mentioned on the previous slide, treating any underlying conditions and address the environmental factors. Certainly, we need to monitor for both effectiveness and adverse effects for sedative hypnotics as we do all medications. Again, the efficacy would be an improvement in sleep or sleep quality, reduction in nocturnal awakenings, being able to sleep through the whole night, reduction in time to fall asleep once they go to, when they retire. So all of these things could be monitored and should be documented in the clinical record. And certainly these agents are not without adverse effects. There is clinical evidence to associate these medications with falls, especially in the morning. Some of the longer acting agents can certainly have a morning hangover. And there's a growing body of evidence to describe confusion and forgetfulness with the use of these meds. In fact, some of them actually in their FDA labeling talk about sleep driving, which many of our residents aren't driving, but it points out the fact that people do things maybe in the middle of the night or after they take them that they don't remember. And certainly if you have a resident that is suggesting that unusual things are happening or they're doing unusual things, if they're on one of these medications, we really need to think about that because, it's possible that maybe those things are happening. Maybe they are getting up and going outside in the middle of the night and doing some dangerous things, and they don't even remember it. So that forgetfulness, or what we call sleep driving, for lack of a better term, is something we do need to consider. These agents also have maximum daily doses. I've listed them in 2 different columns here. One is the benzodiazepines. Temazepam is the classic. Lorazepam is also used for sleep and other conditions, anxiety. The non-benzodiazepines, or the newer agents, are there. Zolpidem or Ambien is probably the most common in that category. Lunesta is also another one. I will point out there is one there, the Ramelteon, which is listed as a maximum of 8 milligrams. It's actually a melatonin type drug. And that one is not a controlled substance, which puts it in a little different category than the rest. And it is also one for which the labeling actually doesn't list or isn't as strongly in recommendation of short-term use. So that is one that's kind of a little different than the other agents in that group. There are certain sedative hypnotics that have traditionally been used that we really should not be using, and I've listed those on this slide for you. Of note, diphenhydramine or Benadryl is really on the top of the list, and it's a drug that I do not like to see used in the older adults. Sadly, because it's an over-the-counter drug and it's been around forever, people tend to think it's safer than some of the other sedative hypnotics, but in reality, we know that in the older adults, the anticholinergic effects, the cognitive effects of this drug can actually be very, very debilitating for older adults. So diphenhydramine as well as hydroxyzine, which has a lot of antihistamine properties, also known as Vistaril or Atarax, are probably two that I really don't like to see used in the older adult. I don't really know of too many people using chlorohydrate anymore, and certainly flurazepam, which is a very long-acting sleeping agent, a benzodiazepine class, is one that we should not be used either. I really don't know of anybody using barbiturates for sedative hypnotics either, but again, those are considered inappropriate for sedative hypnotics. So again, the duration is the big issue with sedative hypnotics. We do recommend that they are used for the shortest time possible, if possible to avoid daily use. So if a person needs an occasional sleeping agent, it's better to try to limit that to a couple times a week rather than certainly daily, because we do have evidence that daily use really is associated with more side effects and actually a reduction in efficacy after a period of time. Again, the manufacturers, if you look at their labeling, will actually, for the most part, list these agents are for short-term use. So consequently, that we do have the gradual dose reduction requirement for this class of agents. And it's listed here for you. It is basically a quarterly requirement, and that needs to be documented and monitored. So if we do this, certainly during that time period, we want to monitor those sleep parameters, both the side effects and the efficacy. And certainly, we can have a contraindication to the gradual dose reduction with sedative hypnotics, just like we do with the antipsychotics, that if we've tried this repeatedly and the resident just does not sleep and they have impairment in their function or possibly psychiatric instability and the target behavior or symptoms returned, we can certainly label that as a contraindication. For the remainder of this talk, we're going to talk about the third class of drugs listed under unnecessary medications, and this is the psychopharmacological class. And this is probably the newest group of meds that were added, and it's a very broad class, and it actually includes some medications that in the past really weren't regulated and didn't really get mentioned in the nursing home regulations. And this broad class is defined by what the medication is used to treat. So it's defined as any medication used to manage behaviors of any kind, to stabilize mood, or even treat a psychiatric disorder. So you can see this covers a broad category of medications and uses, and it's often referred to in the regulations as those meds used for those conditions that I just mentioned, other than antipsychotic or sedative hypnotics. So, we have the antipsychotic and the sedative hypnotics pretty well spelled out in the previous sections of this regulation. So now we're going to take a whole new class, very broadly defined, and include them. So this slide is kind of important to understand, because if you look at it, we have three fairly broad categories. We have anxiolytics, we have anticonvulsants, and we have antidepressants. And certainly there's a lot of overlap between these, and it makes for some very, very confusing slides coming up, and I apologize for that. But if we try to think about these as anxiolytics, anticonvulsants, and antidepressants, and then we'll talk about each of those major categories. Where it really gets confusing is when we have an antidepressant, because we know that certain classes of antidepressants are used for anxiety as well as antidepressant use. So we have to be cognizant of what the indication is and how they fit into this regulation. I have put a little asterisk by some agents that were previously not regulated. Of note, antidepressants in the past have been mentioned in regulations, but there was really never a well-defined need for a gradual dose requirement for antidepressants. That has changed with this regulation, some of which I'm not sure I totally agree with, but certainly they are mentioned now in terms of gradual dose reduction, as well as the use of anticonvulsants for behaviors. So there are exemptions because, as we know, that these broad classes of medications have lots and lots of other uses other than to manage behaviors. So certainly if we're using any of these for neuromuscular conditions such as cerebral palsy, restless leg, or seizure disorder, we do not need to worry about the gradual dose reductions. That would be considered clinically contraindicated. Certainly we use long-acting benzodiazepines to taper from short-acting. And certainly there are exemptions if these medications are used for symptom relief in end-of-life situations, in terminal illnesses or hospice care. So let's talk about the anti-anxiety medications or the anxiolytics. That Appendix PP in the State Operations Manual, which I've referenced at the end of this presentation, you're going to see a table called Table 1. And Table 1 has many, many medications listed, and it lists a lot of information about each class. Some of them are individual medications listed in that table. Anxiolytics has its own section there, and they talk about some of the concerns we have, and a lot of them deal with the potential side effects of the anxiolytic class. We need to remember when these agents are used for symptoms of delirium, dementia, and other cognitive disorders, that those behaviors, again, just like with the antipsychotics, they have to be quantitatively and objectively documented. So again, we want to say exactly what the patient is doing. How is this anxiety or delirium or dementia or whatever disorder that we're treating the symptoms of? What are those symptoms? And how many times per shift or per time period are those behaviors being exhibited? Those have to be monitored to justify continued use of these medications. And certainly when we do our gradual dosing reductions, we're going to want to look at that behavior monitoring flow sheet to determine what has happened as we've tried to reduce these doses. Have things gotten better? Have they gotten worse? Have they stayed the same? So we need to think about those target behaviors very objectively. The behaviors must be persistent. And again, we need to rule out all the preventable causes, other meds. We certainly know that there are medications, again, some of the stimulating meds, actually some of the antidepressants we use can actually cause anxiety or insomnia and stimulated behaviors. And certainly these behaviors that we're treating should be shown to cause significant distress or dysfunction. And again, we have the danger to self or others. For monitoring of anxiolytics, we certainly want to look for efficacy. We want to look for improvement or maintenance of their mental, physical, or social well-being. Again, I'll just repeat, those target behaviors need to be very objective and very quantitative. And as far as adverse effect monitoring for this broad class of drugs, those are going to vary by class, and I'm going to talk about those as we talk about the individual agents and classes of agents. Probably the most common class of agents and the longest used class of agents for anxiety are the benzodiazepines, of which Librium or chlordiazepoxide or Valium or diazepam are the prototypes. These agents have been around for decades. We all know some of the problems with these agents. Certainly, from a nursing facility standpoint, they're controlled substances, so that requires counting, which is a minor inconvenience. But in addition to that, they're associated with some pretty significant adverse effects. We have very good evidence to associate these agents with falls. And of course, we know in our older adults when they fall, some really bad things can happen as far as fractures, confusion, sedation, and again, forgetfulness, amnesia type things. So many times the behaviors that we're trying to treat can actually be exacerbated by using these agents. The benzodiazepines also have their maximum daily doses. And the regulations aren't as specific as they used to be when they reorganized the regulations under the psychopharmacological medications section of unnecessary drugs. They kind of changed things around a bit. We used to be really concerned about long-acting versus short-acting benzodiazepines. It's not mentioned so much in the regulations, but I will say that in my personal experience and opinion, we do want to avoid those longer-acting agents like chlorodiazepoxide, chlorazepate, and diazepam. And I see I have a typo on this slide. That should be clonazepam, not D-clonazepam. That's the fourth one down. We want to use the shorter acting agents if we can, on as limited amount as possible. The shorter acting agents have less accumulation in the body, and they're going to be less likely to be hanging around for long periods of time, causing increased blood levels. So things like lorazepam would probably be a reasonable choice for short-term use if necessary. Again, we have a couple anxiolytics. These are not the benzodiazepine class, but these are agents that I mentioned under sedative hypnotics that we really don't like to use, but historically have been used as sedatives and anxiolytics. And that's diphenhydramine or Benadryl or hydroxyzine and Vistaril or Atarax. These agents have a lot of anticholinergic side effects, and those can be very, very counterproductive when we're trying to treat things like anxiety associated with cognitive dysfunction. Buspirone is listed now as an anxiolytic that needs to be monitored, and it is subject to the gradual dosing reduction. It is kind of an unusual agent for anxiety. It's a totally different class than the benzodiazepines or the antidepressants that we use for anxiety. It is an agent that is not really effective as a PRN medication. It is a scheduled medication. There currently is not listed a maximum daily dose of this agent, but if it is being used, it does need to be considered an anxiolytic and monitored and dose reduced as those agents are too. Now, the antidepressants, this is where it gets kind of confusing. The antidepressants are listed under the subheading anxiolytics in the psychopharmacological agents section, and then they also have their own standalone setting where basically they're being used as antidepressants, which is classically what they're used for. But we do need to realize that of the classes of antidepressants we have, many of them are used for antidepression, many of them are used for anxiety, and some of them are used for pain control or prophylaxis of pain. And so it kind of depends on the use, but the gradual dose reduction requirement is the same regardless of how they're being used. So monitoring of these agents, we have some very specific monitoring parameters. Again, the target behaviors. I probably am beating this horse pretty hard right now, but again, I would just reiterate that those target behaviors really need to be objective and quantitatively documented, exactly like we did with the sedative hypnotics and the antipsychotics. And efficacy, of course, depending upon the indication. Is it for mood or is it for anxiety? We do need to always keep in mind with these agents that we need to look for improvement of symptoms as well as potential worsening of symptoms and suicidal behavior. And again, I want to mention the FDA black box warning. Antidepressants have a black box warning also. Not quite to the same degree of scariness as the antipsychotics do. And truly the black box warning for these agents, you might say, really doesn't affect our age group, because the black box warning is primarily for children and young adults and adolescents. And it really deals with increase of suicidal thoughts and ideation upon initiation of these agents. And in fact, the black box warning goes on to say that in adults over 65, that this may not be the case. However, we do need to be aware of this potential possibility, and realize that that we do need to monitor for that because it can be a serious condition. We also want to realize that many of the antidepressants have similar side effects. On this particular slide, I've tried to denote those side effects that are maybe specific to a class or two. But we have many different classes of antidepressants, and it's kind of beyond the scope of this lecture to talk about that. But I just want to briefly mention that we have the traditional antidepressants, the tricyclics or the TCAs, things like nortriptyline, amitriptyline, imipramine. Those are older agents associated with more of the anticholinergic side effects. Oftentimes are probably not considered the first choice in the older adult. With the exception of nortriptyline, they all have pretty serious side effects. Nortriptyline, on the other hand, in moderate or low doses, can be fairly safely used in the older adults. We have the oldest class of antidepressants, which hardly are used anymore, the MAOIs or monoamine oxidase inhibitors, generally considered not the best choice for use in the older adults or in anybody really because of a lot of significant interactions with other drugs and foods. Then we have the newer agents, the SSRIs or the selective serotonin reuptake inhibitors. Celexa or citalopram, Prozac, or fluoxetine are the classics of those. Those tend to have less side effects in the older adult than generally preferred. However, they can have some issues too, as mentioned on this slide with hyponatremia. And then certainly we have newer agents, the SNRIs, the selective or serotonin norepinephrine reuptake inhibitors, such that are newer. And they all have their own slightly different side effect profile. But for the most part, they're all monitored fairly similarly as far as their effects based on what their indication is for. And many of them are used, as I said, for both anxiety and depression. And in addition to that, they can also be used for pain. Of note, when these agents are used for pain, they are exempt from the gradual dose reduction. So if we have, say, a patient with neuropathic pain or just any kind of persistent pain, and we're using an SSRI or an SNRI for those in conjunction with pain medication, as long as that's well documented, I think you'd have a very good case for not trying to reduce that. So the anticonvulsants is the next group that we're going to talk about. Again, these are meds that are used for quite a few different indications. Certainly, they are required to have a gradual dose reduction if they're used to manage behavior or stabilize mood or treat any kind of psychiatric disorder. And they're exempted from that gradual dose requirement if they're used for, again, neuropathic pain, prevention of migraines, or seizure disorder. The monitoring, again, if we're using an anticonvulsant for behavior, we should be monitoring behavior. We should, again, have those target symptoms, and again, they should be objective and quantitatively documented. And just of note, some of the anticonvulsants, we do have recommended serum concentrations. Those serum concentrations are really there for maintenance of seizure-free intervals. The serum concentrations are not really appropriate to monitor as far as for efficacy. A case could be made for doing occasional serum concentrations to avoid toxicity, but just because we have serum concentrations, that would not necessarily qualify as appropriate monitoring for an anticonvulsant that's used for behavior stabilization. Anticonvulsants certainly have a lot of adverse effects also, and they vary by agent. This is just a list, and it's pretty much all over the place as far as what medications we're talking about. The anticonvulsants that are commonly used are things like valproate or valproic acid, Depakote or Depakine, things like carbamazepine or oxcarbamazepine, Tegretol. Those are agents that are used quite often, and many of them do have some fairly significant side effects that we do need to monitor for. And that's one of the reasons why they're not considered this totally safe agent to use in the older adult. One thing I do want to note on the last slide is that last bullet point, confusion or interference with concentration. That's something that we need to always be cognizant of. And certainly some are more prone to cause this than others. But when a person is started on an anticoagulant or an anticonvulsant, we do need to note for worsening of this ability to concentrate or increasing confusion. It certainly could be a side effect of the medication, which would definitely be counterproductive. So for the psychopharmacological agents, and this includes all the the medications we've talked about in this class, the anxiolytics, the anticonvulsants, and the antidepressants. All of them fall under this psychopharmacological gradual dose requirement recommendation. And they're all required to go through this. And this includes, believe it or not, antidepressants when they're used for depression. Now, I can't necessarily say I agree with that. I think there are cases to be made for an older adult with a long-standing history of depression with multiple episodes where I don't necessarily think it's in the best interest of that patient to try these gradual dose reductions. But the regulations are pretty clear in that they say that we should attempt. Certainly we can have good clinical evidence and we can make a case for those individual residents that we feel would be quite dangerous, and we still can use that clinical judgment. But for the most part, all of these agents, we need to try a dose reduction within the first year. And it needs to be tried on 2 separate quarters with at least 1 month between. And this sounds a little bit familiar because it's very similar to the set of hypnotics. And then after that, it needs to be attempted at least annually. So certainly there's contraindications to this gradual dose reduction. If we have evidence that our use or continued use is within our current standards of practice and we have a clinical rationale. So I could certainly make a case for that person that has a long-standing history of depression with numerous episodes that took quite a while to get under control. I could certainly make a case for not reducing the antidepressant for that person. However, remember, if we're using these for anxiety or behaviors associated with dementing illnesses, we do need to remember that the clinical course of those illnesses might be such that those behaviors and those symptoms might actually go away. So in those cases, it would probably be appropriate to try those GDRs. And with that, I will leave you with the references. Again, the references the reference that I used for the majority, actually all of this talk, is the State Operations Manual, Appendix PP, and it is available free of charge at the CMS website, which is listed there on your screen, or you can Google State Operations Manual PP, and I think it'll take you to the CMS website also. I did access this on September 24th, 2010, and it was accurate at that time. And at this time, I'd like to thank you for your attention. And I look forward to visiting with you again. Thank you.